Good afternoon, Madam Chairperson, and all the virtual audience attending the 6th ICMH. The COVID-19 pandemic has brought an extraordinary situation uh, in all walks of life, including the delivery of medical education. So in an effort to maintain social distancing and prevent community spread, many countries had closed their schools and colleges. And in South Asia, even before the lockdown in India was announced in March, schools and colleges, including medical schools, were closed. And while some regulatory bodies in the West had advocated for early graduation and registration of medical students into making them, to enable them to make meaningful contributions to the health system, others have cautioned the medical students against the taking up roles beyond their competence. And then the other reason why medical students are being brought forward into participation, to participate into clinical management or take up clinical responsibilities is because of their younger age, and on the other hand, due to the higher risk of complications and mortalities amongst those elderly and elderly healthcare workers. Bhutan, as you know, still does not have a medical college, and with a doctor-patient ratio of 5 per 10,000 doctors per 10,000 population, we still face shortage of doctors, and most of our doctors are still being trained in the medical colleges in Sri Lanka, Bangladesh, Thailand, and India. So after Bhutan reported its first COVID-19 case in March 2020, the government took a decisive action to recall 46 postgraduate doctors who were undergoing specialization in other countries, and also to evacuate more than 100 medical students back to the country. And this happened in March and April 2020. Now, when the students and the doctors returned back to Bhutan in March and April 2020, like thousands of other Bhutanese who were being evacuated from elsewhere, they had to remain in a 21 days facility quarantine. So during that period, we did our study. Among the medical students who had returned from India, Sri Lanka, and Bangladesh to assess their knowledge on COVID-19 and to assess their attitude towards their participation in COVID-19 responses. So this was a cross-sectional study among the medical students who had returned at that time and when they were during the 21 days facility quarantine. The sample size was calculated at 129 based on the sample size of proportions with a sample size correction of around 480, because now we have around 180 medical students in these three countries. And in the absence of a proper list of medical students coming into the country at that period of time, we had used a convenient sampling. With regard to the questionnaire, we made a self-designed questionnaire for the purpose of this study, and this was reviewed by 7 national COVID-19 experts. And as a result of this exercise, we could bring out the scale content validation index of the questionnaire to 0.96. The data were collected using Google Forms in order to maintain physical distancing, and data analysis was done in Stata. With regard to the results, from invitation sent to 129, we had a response. We received response from 120 medical students, giving us a response rate of 93%. And in terms of the mean age of the sample was 22 years, plus minus 2 years, and the proportion of students were equally distributed from first year to the 5th year. At that time in March, the majority of the median duration of clinical clerkship that the students had attended was 8 months, with an interquartile range of 1 and 18 months. So in terms of the knowledge score, we assess knowledge using 20 multiple choice questions, and if the score we categorize into 3 categories: good, satisfactory, and poor. Good if they scored more than 80, satisfactory if they scored between 60 and 79%, and poor if they scored less than 60%. As you can see here, The majority of the students, 74%, had very good knowledge about COVID-19, and 23% had satisfactory, and very minimal percentage had a poor knowledge. And they had very good knowledge about the case definition, the symptomatology, the mode of transmission, incubation period, prevention, and on local epidemiology in Bhutan, that most of the cases were being imported, the regional centers where COVID-19 tests were performed, and the national COVID-19 hotlines, toll-free hotlines. The students had poor knowledge on the types of invasive modes of mechanical ventilation, and at that time, poor knowledge on the WHO criteria or WHO advisory on home-based, allowing home-based management of non-critical COVID-19 cases. The knowledge was the knowledge was had a significant correlation with the clinical clerkship, the duration of clinical clerkship that they had undergone in the schools and colleges, and it was not related to age, sex, or in which country these students studied. Am I audible? Okay. Okay. So in terms of the sources of knowledge, as you can see from here, social media, television, and newspapers constituted the majority of the source. 85% reported that they depended on the Facebook page of the Ministry of Health. 67% reported that they depended on the Facebook page of the Prime Minister's office. 78% used televisions, and 63% used newspapers. The use of only 43% had used scientific journals as a source of information, and very minimal, 26% had received lectures and symposium from their respective colleges. So as you can see, there's a shift in trend where social media predominates as the source of information on COVID-19 among medical students. In terms of attitude, the majority held positive attitude towards participating in the government's COVID-19 response. As you can see, 70% responded that they can handle non-clinical job responsibilities such as communication, whereas others were willing to participate in any other form if the government engaged the medical students. And in terms of the fear among medical students if they participated in hospitals was that only 7% reported about having fear in getting infected if they were engaged by the government. So in conclusion, I'd like to say that through this study, we found that the overall knowledge on COVID-19 was good among the medical students, and the students knew about the key clinical and epidemiological information about COVID-19. The learning occurred mostly through self-learning, which reflects a very unique trend where social media predominated as the source of information. The use of social media among medical students as a source of COVID-19 is similar among other medical students, such as that reported in Jordan and Turkey during this pandemic period. And overall, this represents that social media can be used as an effective tool in providing and sharing real-time information about COVID-19 among the medical students. In terms of attitude, the majority held positive attitude, and this is very important because it has been suggested in many countries around the world that medical students can be engaged in hospital activities and clinical activities so that the other routine health staff can be free to attend into COVID-19 responses. And lastly, we have talked how much the medical students can help us, but we should also realize what is the impact of these pandemic on the medical students, especially the Bhutanese medical students studying in the South Asia region. So for Bhutan, because of the disruption of the undergraduate medical training, because of this COVID-19 situation, it will have a major impact on the supply of doctors into our health system. So Bhutan, as you know, Bhutan is still dependent on the medical colleges in the South Asia region to address the need of doctors in our country. So this is not only going to impact their entry into Royal Civil Service, but also their subsequent career progression, including their postgraduate medical training. Thank you.